So now we are going to discuss subcutaneous fungal infections, its agents and diagnosis. Basically, it includes the spectrum of subcutaneous mycosis. It includes many diseases. For example, mycetoma, sporotrichosis, chromoblastomycosis, pheomycosis, hyphomycosis, entomophthalmomycosis, subcutaneous zygomycosis, rhinosporidiosis, basidiobolomycosis, conidiobolomycosis, and lobomycosis, out of which we are going to today discuss mycetoma, rhinosporidiosis, sporotrichosis, chromoblastomycosis, and pheohyphomycosis. So first of all, subcutaneous mycosis, in which the first topic we are going to discuss is mycetoma. It is basically a chronic granulomatous infection of the subcutaneous tissue, usually affects the foot and rarely affects the other parts of the body. It is also referred to as Madura foot or Madura mycosis. Basically, there are two types of mycetoma, eumycetoma and actinomycetoma. The eumycetoma is caused by the fungi filamentous fungi, and the actinomycetoma is caused by the bacteria Actinomycetes. There is a third type which is also called as botryomycosis. In this, a mycetoma-like condition is caused by the most common bacteria, which is the Staphylococcus aureus. Important causative agents of mycetoma. In eumycetoma, the most common agents are Pheochromonas, Leptosphaeria, Madurella mycetomatis, Madurella grigia, Pseudoescherichia boydii, Exophylla genselmai. And basically, the color of the grains depend upon the different causative agent. And in actinomycetoma, the various causative agents are Actinomadura madurae, the grains of which are white yellow in color; Actinomycetoma pilitrae, which is red in color; Nocardia brasiliensis, which is white in color; and Streptomyces somalensis, which is yellow in color. So what is the clinical manifestation of eumycetoma and actinomycetoma? In eumycetoma, the tumor is single, well-defined with margins, and the sinuses appear late and they are few in number. Whereas in actinomycetoma, basically the tumor is multiple tumor masses with ill-defined margins are there, and they appear early, and numerous sinuses appear with raised inflamed openings. The discharge in eumycetoma is serous, whereas in actinomycetoma it is purulent in nature. Grains are black and white in eumycetoma, whereas white and red in actinomycetoma. The bone lesions is osteosclerotic in eumycetoma and osteolytic in actinomycetoma. And basically the grains contains fungal hyphae, which is greater than 2 micrometer, and in actinomycetoma the filamentous bacteria is present, which is less than the grain, it is basically less than 2 micrometer. इसमें pathogenesis in the causative organisms, it basically enters the body from the contaminated soil, usually through a minor trauma or a thorn prick. It begins as a subcutaneous swelling, usually of foot, which enlarges and burrows into a deeper tissue, जिसके कारण characteristic abscess formation हो जाती है. The abscess bursts into chronic multiple sinuses, as we have discussed it, discharging viscid seropurulent fluid containing granules. The color and the consistency of the granules vary according to the causative agent, as I have already described it. The characteristic triad sign of mycetomata is basically the tumefaction, multiple discharging sinuses, and formation of characteristic granules according to the causative agent. In the laboratory diagnosis, the specimen collection, grains collected on a sterile gauge by pressing the sinuses from periphery or by using a loop. On the direct examination, granules are washed with a sterile water and it is crushed between the slides, and then it is examined. So in the direct microscopy, macroscopic appearance of the granules, we can see the color, size, shape and texture. In suspected eumycetoma, the KOH mount hyphae of 2 to 6 micrometer along with the chlamydospores at the margin can be observed. Suspected actinomycetoma, in the gram staining, as it is caused by the bacteria filamentous graft positive bacilli, which is approximately 0.5 to 1 micrometer wide, is seen, and in modified acid fast staining the nocardia is basically identified as weakly acid fast. Histopathological staining of the granules depicts a granulomatous reaction with palisade arrangement of the hyphae in the semen substance or bacteria at the margin. That means semen substance can be observed the hyphae can be observed in the semen substance in the palisade form of an palisade arrangement, whereas bacteria are seen at the margins. Culture of the granules from the deep biopsies is done in the eumycetoma on the SDF for mycotic mycetoma. So here is the picture which is depicting the Madura foot. Treatment is by the surgical removal of the lesion, which is followed by antifungal agents for the eumycetoma, and the preferably itraconazole or amphotericin B for 8 to 24 months is given. And antibiotic for actinomycetoma, that is for the bacterial, which is caused by the causative agent is the bacteria such as Welch regime, which includes the amikacin plus cotrimoxazole. Now the sporotrichosis. It is a nodular ulcerating late disease of the skin and the subcutaneous tissue, and the fungus gain access through the thorn and picks and some injuries. The causative agent is very important. It is basically the Sporothrix shankai, and it is a dimorphic fungus, and it is also known as Rose Gardner disease. So basically the question can come in the form of a Rose Gardner disease. So you have to write the sporotrichosis in it, and the other clinical types of this disease is osteoarticular type, which is seen among the alcoholics, pulmonary type, which is seen after the inhalation of the spores, and it is seen specifically in the chronic obstructive pulmonary disease patient. Disseminated itself means that that the patient immunity is immunocompromised, and that is it is seen in AIDS patient. And there is a fixed cutaneous type, that is a single nodule is formed, that is less progressive, and there is no lymphatic involvement. So in the laboratory diagnosis, direct microscopy, the specimens such as pus aspirate from the nodules are subjected to the KOH preparation, which demonstrate the yeast phase. And histopathological staining of the tissue sections depicts the cigar-shaped asteroid bodies. So in the laboratory diagnosis, direct microscopy, the specimens such as pus aspirate from the nodules are subjected to the KOH preparation, which demonstrate the yeast phase. And histopathological staining of the tissue sections depicts the cigar-shaped asteroid bodies. So the asteroid body, it is a central basophilic yeast cell which is surrounded by radiating extensions of eosinophilic mass and is composed of antigen antibody complexes. Such eosinophilic halo, it is called as splendor Hople phenomena, and it is very important. A question can come on it also, and is observed in zygomycosis, candidiasis, aspergillosis, and blastomycosis. So basically, a central basophilic yeast cell is surrounded by an eosinophilic mass, that is radiating extensions of eosinophilic mass, and the central it is composed of antigen antibody complexes. So the culture, it is also done in SDA medium, that is the saprodextrose agar, and it occurs in the yeast phase in the tissues, and in cultures at 37 degrees centigrade, and in mycelial phase in cultures 20 to 25 degree centigrade, that is dimorphic fungus. So that means it can grow in both the temperatures, that is 22 to 25 degrees centigrade and 37 too. Skin test sporotrichine antigen is used to demonstrate the delayed type of hypersensitivity reaction, and in serology, latex agglutination tests can be done. The treatment of choice for the sporotrichosis is itraconazole. Last but not the least, rhinosporidiosis. It is a chronic granulomatous disease which is characterized by the formation of friable polyps are formed, and the organism which is involved in it, the causative agent, it is the Rhinosporidium seabury. The mode of infection is not known because most infections occurs in the males who have frequent contact with the stagnant water or aquatic life. Laboratory diagnosis. In this, the fungus has not been cultivated, and the diagnosis depends on the sporangia in the tissue sections that is stained with the hemotoxylin and eosin stain. Treatment basically includes the excision of the friable polyp, radical surgery with cauterization to avoid the bleeding as the mainstay of the treatment. Dapsone is found to be effective, and reoccurrence is basically common in these kind of patients. Now the chromoblastomycosis, slow-growing chronic subcutaneous lesion caused by a group of dimetaceous or phyoid fungi, that means darkly pigmented or black fungus, that produces a characteristic morphology called as the sclerotic body. So the agents of chromoblastomycosis is Fonsecia pedrosae, Fonsecia compacta, Phyllophora verrucosa, Cladosporium caroni, and Rhinocladelia aquaspersa. Lesions are basically slow growing and they are polymorphic. Verrucose, that is the most common type. It can be crusted also, ulcerative or nodular or tumor-like also. So the presentation is varied. And the most important feature is the sclerotic body. So what is the sclerotic body? It is the brown, thick-walled round cells which is approximately 5 to 12 micrometer in size with multiple internal transverse septa, which is also called as the medullary body or muriform cells or copper penny. So the question can come in the copper penny or muriform or medullary bodies too, and the treatment is the surgical removal, that is the cryosurgery or laser therapy of the lesion, followed by the antifungal, that is the itraconazole. So this picture is representing the chromoblastomycosis, which is basically the verrucose form of a lesion presenting, and this is the picture of the patient representing the disease. Last but not the least, thank you everyone for listening. Thank you.